Hello, my name's Claire Byrne. I'm a consultant colorectal surgeon and I'm going to show you how I make a colostomy. This patient's got an obstructing rectal cancer. It's irresectable, it's not suitable for stenting. She's actually had a stent previously and there's been growth into it. So she's going to have a defunctioning loop colostomy.
So, Miss Byrne, just before we start, what's the meaning of this laparoscopic port in the umbilicus?
In this case, I put a laparoscope in beforehand to identify a suitable and freely mobile part of the sigmoid colon to use for the colostomy. But not everybody does this, and it's by no means essential.
We've just missed you incising the skin. Can you just talk us through what you do?
I make a cruciate incision, and then I join the points of the cross together to make a circle. I then pick up the skin edges with toothed forceps and using diathermy deepen the incision. That's not the only way to do it. Some people make a freehand circular incision, others use lanes or similar forceps to pick up the skin, lift it up and cut parallel to the abdominal wall to get an amount of skin off.
Okay, and what are you doing next?
I'm using Alice forceps to excise a cone of fat. This lady don't always do this, but this was a particularly fat patient and I was worried about getting the bowel through the abdominal wall.
So how big should the trephine be?
I think the skin incision should be about 3 to 4 centimetres in a person of average build, obviously a little bit bigger if they're chunkier than average and smaller if they're... So I've put in 2 Langenbecks and here I'm showing you the anterior rectus sheath, which I'm now going to incise with a scalpel. This is going to be a cruciate incision and it's going to be slightly smaller than the skin incision. So here my cruciate incision is complete and you can see the muscles of the rectus abdominis underlying it. And now I've introduced some Mackindoe scissors and I'm using these to separate the fibres of the rectus abdominis, not cut them. Langenbeck's retractors are now going to be used to separate these fibres, and at the base of the incision now we can see the posterior rectus sheath, which at this level would be fused with the peritoneum. So now I'm picking up the peritoneum between 2 clips, feeling between them to make sure there's no bowel in there, and safely entering the peritoneum. Again, exactly as you would for an appendicectomy. Here I'm putting my head in the light.
So once you've entered the peritoneal cavity, how do you identify the bit of bowel to bring up?
Basically, you just put 2 fingers inside and feel for the bit of bowel directly underneath the trephine. If the trephine's in the right place, you'd be jolly unlucky to find anything else. And then with your 2 fingers, you just gently try to exteriorise it. You can put a Babcock or a Duval on it to help pull it out if you need to. So here's the bowel being delivered through the trephine. We know immediately that it's colon because of the appendices epiploicae, and you can just see the taenia as well. Just beware because some people have a very mobile cecum which occasionally can sit a lot lower and a lot further over to the left than you might imagine. Once the bowel is out, you can use a finger to run down either limb of the bowel to confirm the orientation. Okay, so once you're happy that you've got the correct bit of bowel and that you've got the afferent limb superiorly and the efferent limb inferiorly, incise about 1/3 of the circumference of the bowel using the diathermy, going through all the layers of the anterior wall of the bowel, taking care not to damage the posterior wall of the bowel, as you can see that I just have. So the next thing to do is to fix the open bowel wall to the skin.
And how do you like to do that? What do you use?
Here I'm using a 2-0 braided absorbable suture. Normally the first stitches are put in the north, south, east and west positions and then stitches to fill in between them. It's really important that you get a good bite of the skin and that you take a good bite of the serosa of the bowel wall because you don't want this to come apart or give way. In between the north, south, east and west stitches I just put 2 or 3 extra interrupted stitches depending on how big the stoma is and however much it needs.
And the really crucial thing there is each stitch gets the serosa, isn't it? A big bite of the serosa.
Yep. At the end of the operation, it's important just to introduce your finger through the afferent and the efferent limb of the stoma to make sure that the opening in the muscles is big enough and that there's not going to be an obstruction.